Hi, welcome back. I'm Dr. Bhargava. In this short video, I have a few interesting cases to share with you. This is our first patient. They underwent a gastric emptying study, and on these images, we find anterior and posterior spot views at different time points after they had ingested a standardized meal. Here's the first image labeled 0 minutes, and here's the second image labeled 60 minutes. So we can see that most of the stomach has emptied before an hour. So this patient probably has accelerated gastric emptying. After the technologists put in the region of interest around all of these images and using the geometric mean plot a time activity curve, we are able to see and report these numbers, which are retention in the stomach at different time points. So at the end of 1 hour, their gastric retention is 23%, which is significantly low. At the end of 2 hours, it's only 16%. So this patient definitely has accelerated gastric emptying. And here are the numbers that we go by. And so in terms of the retention, a lower value at these two time points suggests rapid gastric emptying. So at 1 hour, if the retention is less than 30%, we call accelerated gastric emptying. And so what causes that? These are some of the causes that are related to surgery, and followed by some causes that are related to or are seen in people who have not had surgery. And these include recently developed diabetes, especially type 2 diabetes, pancreatic exocrine insufficiency, duodenal ulcers, and Zollinger-Ellison syndrome. Here is our next patient. We are looking at a whole body bone scan in anterior projection and a corresponding CT of the chest with IV contrast. So the CT shows this tumor in the right breast and associated skin thickening. And this is a patient, they were newly diagnosed with breast cancer, and the whole body bone scan was performed for staging to look for bone mets from the breast cancer. I'm not showing you the posterior image, but it was negative for bone mets, which are usually seen as multiple scattered foci of intense uptake involving the axial skeleton. Here, the interesting finding is diffuse increased uptake of technetium-99m MDP in their right breast, and that's probably related to hyperemia and corresponds well to this CT where we see skin thickening and a mass, that's their primary breast cancer, in the right breast. Here is an interesting article on the topic, and here the authors summarize that although FDG PET is superior to bone scan for the detection of bone metastasis from breast cancer, this technique has limitations in depicting osteoblastic bone metastasis. This is our third patient, very interesting, a female with hyperthyroidism, and when we performed a thyroid uptake and scan, this is the anterior image from their scan, and the 24-hour uptake value was 85%, which is very high. And so looking at this image, we find that there is diffuse increased uptake in the left lobe of thyroid. The right lobe of thyroid is enlarged and shows increased uptake, but then there is a cold nodule at the midpole. And in this situation, correlation with ultrasound is very important. So let's look at some corresponding ultrasound images on this patient. So here is an axial image showing the left lobe of thyroid, the right lobe of thyroid with suggestion of a nodule, and here is the isthmus. And the top right image is the long axis view of the right lobe of thyroid showing this nodule with some vascularity. It's a solid nodule. And here is a similar long axis view of the left lobe of thyroid. It is normal in size, uniform in echogenicity, and there are no nodules seen. And here's again that nodule in the right lobe of thyroid. So this nodule is seen as a photopenic defect on the scan, and this nodule needs to be biopsied and a cancer needs to be ruled out before this patient can be treated with radioactive iodine for their hyperthyroidism from Graves' disease. Now, this condition where the patient has Graves' disease and they have nodules that do not respond to thyroid stimulating immunoglobulins but will respond to TSH is called Marin-Lanhart syndrome. And here's the first paper published by doctors Marin and Lanhart describing this situation where Graves' disease patient can have solid nodules which do not respond to thyroid stimulating immunoglobulins but will respond to TSH. So that's called Marin-Lanhart syndrome, and that's what this patient had. Thank you for watching.